Hello, good evening everyone. Welcome again to the OBIDS rounds. This involves three hospitals, Makati Medical Center, East Avenue Medical Center, and St. Luke's Global. I'm not sure if is there somebody from St. Luke's Global who is able to attend? I invited them, but I don't know. Okay, so today, this is our topic, septic pelvic thrombophlebitis and toxic shock syndrome. So these are rare conditions already in obstetrics and gynecology because of better management and good antibiotics. May I know if you have ever encountered cases like this? In East Avenue Medical Center, have you encountered septic pelvic thrombophlebitis or toxic shock syndrome?
Wala po, ma'am, since I started my residency training po.
Or maybe we already have mga septic abortion. Maybe it's also part of the toxic shock syndrome, although
Yes, ma'am.
sometimes we don't have the culture results. What about in Makati Med? Have you encountered septic pelvic thrombophlebitis?
No po, doctor.
Yet.
Infectious, po, not common in Makati.
Yes. Okay, so these are uncommon conditions. And because now we are very aware, therefore, if a patient is already high risk for developing these conditions, we already institute the management early on to prevent these complications from happening. So I will present a theoretical case. This is a case of a 32-year-old, gravida 1, para 1. On admission, she had an emergency cesarean section. On day 3, postpartum, she developed fever, chills, and abdominal pain in both flanks, stronger on the right side. On blood test, they noted leukocytosis, WBC count of 15,000 with neutrophil predominance and a CRP, elevated CRP of 17. Pelvic ultrasound and abdominal X-ray were both normal. So the patient was treated as endometritis. She was given amoxicillin and clavulanic acid every 8 hours IV. Despite the antibiotic treatment, on the 6th day postpartum, she still had persistent fever and right abdominal pain. But she was not toxic, no? She wasn't septic. So repeat CBC showed an increasing white blood cell count of 19,000 with 85% neutrophil predominance, and the CRP increased to 35. Thus, the antibiotics was shifted to clindamycin IV, gentamicin IV, plus ampicillin IV. However, on day 8 to day 10, she still had persistent fever and right abdominal pain. The white blood cell count already decreased to 13,000. CRP is already lower at 16. However, it's still elevated. On abdominal ultrasound, there was note of a focal lesion in the myometrium. Cannot rule out an abscess in the myometrium. And on pelvic and CT scan, there was note of bilateral heterogeneity in the lumen of the external iliac veins. So this is a question, quiz question. Please write in the chat box, what is your diagnosis? The person who will answer correctly will receive a prize, courtesy of Abbott. So what is the, what is the diagnosis? Asan na yung chat? Teka nga. I cannot see. Ayun, chat. Ayun. All right. Septic thrombophlebitis is the correct answer from PGI Emokling. So, Dr. Emokling, you win a gift certificate for pizza, care of Pizza Hut, thanks to Abbott. Emokling. What hospital are you, Doctora? Doctor or Doctora?
Doc, I'm a DH intern in East Avenue, Doc.
East Ab. O, sige. Alright. So, correct answer. Septic pelvic thrombophlebitis. So, as you can see, on the 16th day postpartum, she still had persistent fever spikes, but there was less abdominal pain. Therefore, the attending physician already thought of a possible septic pelvic thrombophlebitis. Thus, she was shifted to piperacillin tazobactam plus metronidazole, and she was already given anticoagulant of enoxaparin, 40 milligrams once a day subcutaneously. On the 23rd day of postpartum, eventually she became asymptomatic and did no longer have any fever. The WBC count is already lower at 13,200. CRP was normal, and pelvic and abdominal CT scan showed no more evidence of thrombosis. And she was eventually sent home asymptomatic. So, for this case, the diagnosis is septic pelvic thrombophlebitis. So historically, in the 1800s to the early 20th century, mortality rate for septic pelvic thrombophlebitis was high at 50%. And before, in the early 20th century, the cause was usually due to obstetric factors, especially secondary to septic abortion. However, at present, usually we will encounter these cases after cesarean sections, especially if there's a concomitant infection. And also, before, in the early 1800 to the early 20th century, treatment was primarily surgical. So they would excise the area, the thrombus, do surgical excision, or do ligation of the affected vein. So as you can see, the treatment before was very difficult and there was a high mortality rate. But right now, the treatment is mainly medical. So for postpartum septic pelvic thrombophlebitis, this is a one common risk factor is cesarean delivery. So septic pelvic thrombophlebitis occurs in 1 out of 3,000 deliveries. It is more common after cesarean section, 1 in 800, compared to after normal spontaneous delivery, which is 1 in 9,000. So keep that in mind, no? It is more common after cesarean section. You should consider septic pelvic thrombophlebitis if there is persistent spiking fever postpartum that is unresponsive to antibiotic therapy. And usually, this resolves after systemic anticoagulation. And clinical suspicion is the most important aspect for the diagnosis because there's no very specific laboratory test for the diagnosis of septic pelvic thrombophlebitis. It is clinical suspicion. So usually, postpartum, if the patient has spiking fever, the patient is not toxic looking, but despite very good antibiotics, there's still spiking fever, think of septic pelvic thrombophlebitis. So clinically, the patient presents with fever and abdominal pain postpartum. The fever persists despite antibiotic for endometritis. And she may have flank pain or lower abdominal pain. And the pain is characterized as constant and not too severe. On physical examination, she may have abdominal tenderness on deep palpation. So it's a bit similar to the pain of endometritis. So the pathophysiology is due to either ovarian vein thrombophlebitis or deep septic pelvic thrombophlebitis. So what are the factors that contribute to the development of SPT? This is because of a combination of infection, inflammation, and thrombophilia. So we know that sometimes in the setting of infection, such as septic abortion or chorioamnionitis, or if the patient has an existing infection, she has a higher risk of SPT. So in septic pelvic thrombophlebitis, The endothelium becomes damaged because of uterine infection or due to the trauma of delivery or surgery. And then there's also venous stasis. Because of pregnancy, usually the veins are engorged, the veins are dilated, and then there's low postpartum ovarian venous pressure. Aside from that, we know that pregnancy is a hypercoagulable state. So there's a higher risk for the formation of thrombi, thereby leading to septic pelvic thrombophlebitis. Okay. Now, there are two kinds of septic pelvic thrombophlebitis. There's the ovarian vein thrombophlebitis. So this is more toxic, no? A woman with ovarian vein thrombophlebitis, she appears clinically ill. She has a fever, she has abdominal pain located on the side of the affected vein, flank, or back within 1 week after the delivery or surgery. And there are rare cases of pulmonary embolism that can occur if she has ovarian vein thrombophlebitis. So usually, di ba, we encounter patients postpartum, they have flank pain, back pain. So usually we think of UTI, but at the back of our minds, let's also think of possible ovarian vein thrombophlebitis. So in contrast, patients with deep septic pelvic thrombophlebitis usually present 3 to 5 days after the delivery or surgery. They have unfocalized fever, which is the only symptom, and it persists despite antibiotics. And in contrast to ovarian vein thrombophlebitis, they appear clinically well in between fever spikes, and usually there's no pain, so it's only fever, and it's less toxic than ovarian vein thrombophlebitis. So the differential diagnosis for septic pelvic thrombophlebitis are UTI, appendicitis, endometritis, ovarian torsion, and pelvic abscess. So this is so when you have patients postpartum, days 3 to 7 postpartum with fever and pain, don't just think of the usual suspects. Also think of septic pelvic thrombophlebitis. It's usually diagnosed when 5 days of antibiotic doesn't work and when you give anticoagulants, they work. However, some studies would debate the effectiveness of anticoagulants. But other studies say that anticoagulants are very effective in these cases. So probably that is also the reason why we don't really encounter a lot of septic pelvic thrombophlebitis, because now we are very much aware about the dangers of thrombus formation. So we already give prophylactic anticoagulant in high-risk patients. So what are the laboratory tests that can diagnose SPT? So as I mentioned, lab tests are non-specific. There can be mild leukocytosis, usually blood CS is negative, and on imaging, for example, ultrasound and CT scan can show thrombi, but it can miss out also septic pelvic thrombophlebitis. But MRI venography is more sensitive. So as you can see in this illustration, there's a presence on MRI of a thrombophlebitis in the right ovarian vein. So for the management, these are the cornerstones of management: antibiotics and anticoagulants. No? So if the woman has a right ovarian vein thrombosis, which is more serious, no? If it's in the right ovarian vein, the antibiotics of choice are ertapenem or clinda, genta, ampicillin. And we give the antibiotics IV for 7 days. For anticoagulants, we give usually enoxaparin, 1 milligram per kilogram, and then we can also give warfarin. And then the treatment for right ovarian vein thrombosis is prolonged for 3 to 6 months. And then we have to repeat the CT scan after 3 months. If the repeat CT scan doesn't show thrombosis anymore, stop the anticoagulation. But if it's still positive for thrombi, then additional anticoagulation is needed for 3 more months. If the thrombosis is in the pelvic branch vein, we also give the same antibiotic, ertapenem or clindagenta ampi, and then we also give enoxaparin, but the length of treatment is only for 2 weeks. Now, if on CT scan or MRI, there are no pelvic thrombi seen, we give the same antibiotics and we give the enoxaparin for only 1 week. So as you can see, the anticoagulant dose here is not prophylactic but therapeutic. It's 1 milligram per kilogram. Okay. So as I mentioned, give the IV antibiotics. If there's no improvement after 5 days of antibiotic, then we consider SPT. So that is why most of the time we diagnose septic pelvic thrombophlebitis clinically if there's no improvement with good antibiotics. So we give enoxaparin at the therapeutic dose for 1 to 6 weeks, but actually even up to 6 months. Okay. Ayan. So I already mentioned this. Okay. Now we go to another case, no? This is a case of a 28-year-old female. She's not pregnant. She's on her 5th day of menstruation. She developed fever, chills, generalized rash, and on the 5th day of her symptoms, she noted desquamation of the skin on her palms and on the soles of her feet. On internal examination, you noted that she had a foul-smelling tampon that was left in place for already 5 days. So what is your diagnosis? So please write your diagnosis in the chat box, and the person who answers correctly will receive a prize. Okay. Ay, si PGI Emokling uli. Okay. Ito. PGI Hervero, TSS. Okay. Congratulations, Justin May Hervero. So, from what hospital are you?
From DOH East Ave po.
From
DOH East Ave po.
DOH East Ave. Okay. So, both of the winners come from East Ave. Okay. So, can you justify why is this TSS?
So it's TSS because of the history of a tampon left in place for 5 days and the descommitting skin rash po and fever as well.
I can't hear you. Can you put your mouth nearer the mic?
Sorry, Doc. The patient is diagnosed as TSS or toxic shock syndrome because of the history of the tampon left in place for 5 days and the patient manifested a descommitting rash po with fever.
Okay, correct, no? So I have already encountered the case where a tampon was left in place. The patient forgot to remove her tampon, and it was really very foul smelling. She came to the clinic for foul smelling vaginal discharge. Fortunately, she did not have a fever. She did not develop toxic shock syndrome. But I really warned her next time not to forget, okay? Uh, so usually we have to, the women who use tampons should replace them or remove them after 4 hours of use. Okay. So toxic shock syndrome, it is because of exotoxins produced by Staphylococcus and Streptococcus. There are strains of Staphylococcus aureus that elaborate the TSS toxin 1, TSST1, or related exotoxins, and staphylococcal enterotoxin B. There are also certain strains of Streptococcus pyogenes, called the group A beta hemolytic strep, that produce streptococcal pyrogenic exotoxin A, B, and C. The risk factors for toxic shock syndromes are women who have pre-existing staphylococcal colonization of the vagina and who leave tampons, especially the very absorbent tampons, because if the tampons are super absorbent, then usually they're left in place for a longer time. Or other devices such as contraceptive sponges, diaphragms, or even the very popular menstrual cups. However, actually, toxic shock syndrome due to the menstrual cup is very rare, unlike the superabsorbent tampons. and then with coexisting mucosal breaks in the vagina. So for example, if the woman inserted her tampon and then she has a small um, like abrasion or wound in the vagina, which can lead to an entry of bacteria into the bloodstream, she is more at risk for toxic shock syndrome. So the staphylococcus toxic shock syndrome, so usually it's because of, again, staph colonization in the vagina, foreign body in the vagina, but another possible risk factor is if the woman has a staph infection postpartum in the vagina or post-abortion. The mortality rate is low at less than 3%. In contrast, if this is a streptococcal toxic shock syndrome, this can also occur after minor trauma or after surgical procedures, and it is more aggressive than the staphylococcal type. No? There can be 20 to 60% aggressiveness. And 50% can develop sepsis, bacteremia. 50% can develop necrotizing fasciitis. It can be associated with ARDS, and group A streptococcal infection is usually aerobic and gram-positive. The patients who have varicella infection, diabetes, who are alcoholics, or who had surgical procedures are at more greater risk of streptococcal toxic shock syndrome. Now, this is more severe and it can lead to necrotizing fasciitis and spontaneous gangrenous myositis. So streptococcal TSS is more toxic than staphylococcal TSS. So this is a picture of a patient who had staphylococcal TSS. So usually she will have a fever and a rash, and there's a desquamation of the palms and the soles 1 to 2 weeks after the onset of the illness. Now, for severe toxic shock syndrome, there can be a release of exotoxins in the systemic circulations. And if the patient doesn't have any antibodies against staph or strep, there will be the production of exotoxins in the blood circulation. And these are called superantigens. Now, superantigens interact directly with class 2 MHC molecules. So there's no, mas mabilis yung ano niya, may direct interaction with the MHC molecule. And then there's the release of interleukin 1, interleukin 6, and tumor necrosis factors. So yung mga inflammatory cells. And there's activation of massive amounts of T cells as well as interferon gamma, producing an exaggerated cytokine response. And it inhibits polyclonal immunoglobulin production, and there can be the development of shock and tissue injury. So parang it's a little bit like the cytokine storm of COVID, no? Na toxic shock syndrome produces super antigens, and there's a overproduction of T cells and an exaggerated cytokine response. So in the picture, on admission, this woman has severe toxic shock syndrome. She's intubated, but after antibiotics and IVIG, she became much better. Okay. Laboratory tests for the diagnosis of TSS are CBC, there's note of leukocytosis with polymorphonuclear shift to the left. There can also be mild leukocytosis with significant immature neutrophils on peripheral smear. On urinalysis, there can be hemoglobinuria, so blood in the urine. There can also be sterile pyuria. If the patient, of course, is already septic, the PT and PTT are already prolonged. Okay, and then creatinine is elevated. There can be hypoglycemia, low serum protein, low serum albumin, elevated BUN, elevated transaminase, elevated bilirubin. In myositis or necrotizing fasciitis, there's elevated creatinine kinase. And on blood culture, usually in 60%, you can see the group A streptococcus. But a lot of times, if this is a staphylococcal toxic shock syndrome, sometimes the staphylococcus cannot be detected on blood culture. So the signs and symptoms of TSS, there's an abrupt onset of fever. So usually the temperature is 38 degrees Celsius or higher and is persistent. Patient is already hypotensive, and then she has a diffuse macular rash. And the involvement of at least two organs are involved, no? Failure of two organs. In staphylococcal toxic shock syndrome, she may also develop vomiting, diarrhea, myalgia, elevated creatine kinase, mucositis, hepatic damage, thrombocytopenia, and confusion. So staphylococcal toxic shock syndrome rash is more likely to desquamate, particularly on the palms and soles between the 3rd to the 7th day after the onset of the infection. Whereas streptococcal toxic shock syndrome commonly causes ARDS, coagulopathy, and hepatic damage, and is more likely to cause fever, malaise, and severe pain at the site of a soft tissue infection. So how do we manage toxic shock syndrome? Of course, the patient is a septic shock, so we have to do aggressive IV fluid hydration with crystalloids. Immediately remove the source of bacteria. So if this is, of course, an infected tampon, remove it. If it's infected IUD, remove the IUD. If there's infected tissue, there's tissue gangrene or there's necrosizing fasciitis, then we have to immediately do wound debridement to remove the infected tissue and start broad spectrum antibiotics for 7 to 14 days. So if this is due to a staphylococcal infection, it would be wise to cover for MRSA because a lot of staphylococcal organisms now are methicillin resistant. So if it's MRSA, then what we give is clindamycin, gentamicin plus ampicillin. Or we can give vancomycin or linezolid plus genta and ampi. But if this is a methicillin-sensitive Staphylococcus aureus and the patient is not too toxic, we can give flucloxacillin. If this is a streptococcal infection, then we can give any of the penicillins. No? Now, if the patient is in shock, that is refractory to IV fluids, we have to institute vasopressors. And it's also life-saving to give IVIG. So we give IVIG 2 grams per kilogram and admit to the ICU. So thank you very much. Do you have any questions? This is a very short lecture, but I hope that you learned something out of it. So do you have questions or do you want to share? Did you ever encounter infected IUD that caused sepsis? Or what else? Or mga septic abortion where the patient was intubated. Meron ba kayong ganon sa East Ave? Maybe you can share.
Ma'am, pero wala pa naman po. Yung recent referral ko, Doc, considered a septic abortion, pero hindi naman po siya umabot sa intubation.
Septic abortion, pero hindi naman na-intubate. Probably because now the way of inducing abortion is because of misoprostol. No longer the insertion of mga foreign body, right? So we also encounter less cases of really very septic patients after induced abortion. Okay, so now we have my third question is, how many hours should tampon be left in place before replacing it? 4 hours. Thank you. Intern Pamela Agatha Puno. Okay. From what hospital?
From Makati Med po, Doctor.
Okay. So I will give you the even later on, kindly The winners, PGI Enokling, PGI Hervero, and Pamela Agatha Puno, kindly send me your name and your contact number so that our kind sponsor will send your prize to your house. Okay? They will get in touch
I
with you.
already got the numbers ko, ma'am. Will forward na lang po sa inyo.
Sige, sige. What about si Pamela?
Yes, Doc. I already messaged her in as well.
You already messaged. Okay. Okay, so thank you everyone. Do you have any other questions or comments?